Well, very good evening to all of you, and good morning and good afternoon to all of those who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Samir Malinkri from Pune, and he's going to lecture us on bispecifics in the treatment of lymphomas. This webinar is brought to you by Mumbai Hematology Group, supported by Roche, Unipath, Lucien, and Nirvin Life Sciences, and managed by Perfect Square. I thank Team Roche, Unipath, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Samir Malinkri from Pune, all our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 8th of June 2025 from 11:30 a.m. Indian Standard Time and 8 a.m. French time, we have Dr. Hervé Tilly from France speaking to us on large B-cell lymphoma European Management Guidelines in 2025. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will stop for a while for you to have a look on all our discussions for the day. So these are our discussions for the day. Some more names are there. Well, so these are our discussions for the day. Now it's time to introduce our guest speaker for the day. We have no other than Dr. Samir Malinkri from Pune. Just to introduce Dr. Samir Malinkri, he requires no introduction. He's a very well-known figure, but it's my formal duty to introduce Dr. Samir Malinkri, sir. He's a head, Department of Hematology, Director, Blood and Marrow Transplantation at Dinanath Mangeshkar Hospital, Pune. Sir did his MD Medicine from BJ Medical College, Pune. Subsequently, he did his DM in Clinical Hematology from CMC Vellore in 2007. Presently, he is also an Executive Committee member and Secretary of the Scientific Committee of ISBMT. Today is with us and is going to lecture us on bispecifics in the treatment of lymphomas. Well, thank you so much. I stop over here. Over to you, sir.
Thank you, Amit, for the kind introduction. I'm just sharing my slides. Sorry. Oh, sorry, 1 second. Yeah. I hope the screen is visible.
Yeah, but something else is coming, sir. It's a blood article is coming.
Okay, just a second. Okay, 1 second. I'll just stop the sharing. I'll reshare. Yeah. Is this okay now? Amit, is this okay?
It is okay, but some black line is coming upstairs. Yeah, now it's okay. Some one more black. It's okay. Fine. So you can proceed, sir. Yes, sir.
All right. Okay. So the topic is bispecific antibodies in lymphoma, and I'd like to just disclose that as again some of the earlier lectures that I have delivered, where I have sufficient experience in the subject. This is a topic where these drugs are not available in India so far, and my experience is very limited with the use of bispecific antibodies in lymphoma. I have in fact used only in 2 patients, but nevertheless, since it's a very, very important upcoming topic, I think it's worth discussing. Okay, so just to introduce the topic, the treatment of lymphomas has been reshaped with the advent of immunotherapy, including bispecific antibodies and CAR T-cell therapy. And together with CAR T-cell therapy, these drugs offer a higher chance of cure of relapsed refractory lymphomas. And current work is ongoing for their use in frontline settings and in combination with existing therapies. So how do these drugs work? So all the bispecific antibodies work by simultaneously binding target tumor cells with the immune effector cells. And these are predominantly the T lymphocytes, but also sometimes the macrophages, NK cells, which become activated and then cause tumor cell destruction. and the cytotoxicity occurs in a MHC independent fashion, thus bypassing the restrictions imposed by the MHC T cell receptor interaction. Now, this is a very, very important thing because we know that in many malignancies, especially like in DLBCL, the tumor cells frequently exhibit genetic aberrations that abolish the expression of MSC class 1 molecules, and thereby they evade immune attack by the T cells. So these antibodies work by an MHC independent fashion. It should be noted that indiscriminate T cell activation can occur with these drugs, and both effector and non-effector T cells get activated, and the effect of this may last for up to 6 months after the last dose of the drug. Now, what are the targets on the T cells and the B cells? Now, on the T cells, universally the target has been CD3. Whereas on the B cells, multiple targets have been tried in the past, and these include CD19, CD20. These are the commonest. We know that CD19 is universally expressed on B lymphocytes, and also on all the lymphomas which are B cell in origin, CD20 is expressed. In acute lymphoblastic leukemia, we know that the expression of CD20 is only in about 50% of patients, but in lymphomas, it's universally present. Now, earlier, a lot of other targets were also tried. CD22, for example, CD37, CD70, 79B, 138, HLA-DR, all of these have been targets in research. And but it's been found that the latter induce lower cytotoxicity. So, for instance, I remember a patient whom we had sent for CAR-T to China earlier in the past, and they were they were looking at the CD20 and the CD22, and then they thought that the CD22 expression is more, and therefore they decided to do a dual CAR-T against CD19 and 22. But then later on, it's being realized that it's not the amount of expression of the particular antibody as defined by immunohistochemistry or on flow cytometry, or it's not just whether it's dim or bright, what is the percentage of expression. These are less important, and it's now noted that all these other antibodies, including CD22, offer lower cytotoxicity as compared to CD20. CD20 has been found to be the best target, wherein the maximum cytotoxicity is induced by when CD3 ligates with, you have an antibody that ligates CD3 with CD20, even when expression levels of these B cell antigens were comparable. And hence CD20 and CD3 has been the focus of development of bispecific antibodies. So there you have the pictorial description of the bispecific antibody, which is ligating CD3 and CD20 here. And what are the bispecific antibodies that are available and we're going to talk about? These are mosunetuzumab, glofitamab, epcoritamab, odronextamab, plamotamab, and a newer IgM antibody. In brief, I'll just explain the design of these antibodies, how these, what the structure of these antibodies is. So, mosunetuzumab is, it's a standard antibody, like where the FAB fragments are kind of adhered to each other by knobs into holes, kind of a attachment. It's an IgG1 antibody, 1:1 CD20 to CD3. And the CD20 clone is the epitope is similar to that of rituximab. And it should be noted that in all of these, you would have to have an FC silencing mutation, wherein there should not be any FC gamma receptor binding. So if you have FC gamma receptor binding, then you're going to kind of have all these antibodies phagocytized by the macrophages. So you need all of these have no FC gamma receptor binding. Then you have glofitamab, in which you can see the structure here. In addition to have a standard bispecific antibody, the CD20 also is attached in a head-to-tail fusion with the CD3, and therefore that allows a 2:1 ratio of binding. It's got an epitope that is identical to obinutuzumab. Epcoritamab is again it's an IgG1. There's a controlled FAB arm exchange. And the CD20 clone is a type 1 epitope shared by ofatumumab. Odronextamab is again an IgG4 antibody, this time heavy chains with differing affinity. Then you have plamotamab, wherein the CD3 tends to be a single chain variable fragment. And then there is a IgM, which is still under exploratory analysis. Now, what are the FDA approvals for each of these drugs, right? So now there are, I mean, these FDA approvals are, very kind of, this is what we are, where we are today, but very soon, probably in another year's time, these the approvals are going to change and the indications are going to expand. But currently, mosunetuzumab is for follicular lymphoma, glofitamab is for DLBCL, also evolved from follicular lymphoma, epcoritamab is follicular lymphoma and DLBCL. Odronextamab is approved in the Europe by the European Medicines Agency for follicular lymphoma and DLBCL post 2 lines of treatment, but it's not yet US FDA approved. And plamotamab has yet to receive approval. Now we'll come to the data with each of these. And for, so blinatumomab is the, I just put one slide on blinatumomab. So this is, as we know, is the CD3 ligating CD19. It has very good results established in BALL. The problem with blinatumomab is that it is a very short half-life, and hence a continuous infusion is required for 28 days. And I don't know how many of you have used this drug. I've had the opportunity of using it for about 7 or 8 times in the past, and I can tell you that it is a absolutely difficult drug to administer, for the only reason that there are a lot of transfusion related, infusion related issues. So you have to open one vial, you may have to use only a fraction of that vial and then calculate and keep the remaining behind. And then there's a specific dilution, the compatibility with the kind of the syringe that you use, and the syringe pump that you use also very specified. You can't use any syringe pump for this. So it becomes a very cumbersome thing. And so you have to really, especially when patients want to take it at home, it becomes very, very difficult to deliver it at home, at least in the Indian settings. Um, Also, it is less effective than the newer CD3 into CD20 bispecific antibodies, and therefore it is kind of fallen out of favor in lymphomas. The approved bispecific antibodies for RR DLBCL, these are glofitamab, epcoritamab, and odronextamab. And for the sake of, since we have limited time, I'm going to discuss mainly glofitamab and epcoritamab, because I feel that these are the ones which are probably going to get launched soon. Or glofitamab will be launched hopefully in India by Roche maybe next year. And so I'm going to discuss these two. Talk about glofitamab first. So that was the phase 1 study of glofitamab. But we'll speak more about the phase 2 expansion study of glofitamab, which was approved, which was where glofitamab was used after 2 prior lines of treatment in DLBCL. Now, these were patients who had DLBCL or transformed from follicular lymphoma or primary large B-cell lymphoma, and satisfying certain other criteria such as a good ECOG score, etc. 2 or more lines of treatment. And the primary endpoint was CR rate. So most important, you must remember that whether it's CAR T cell therapy or a bispecific antibody, CR is the absolute goal, because if you don't achieve CR, then the results are very poor. Therefore, the primary endpoint of the study was CR. Key secondary endpoints for ORR rate, duration of response, duration of CR, PFS, and OS. Now, how is glofitamab administered? So in the first step, you've got to administer obinutuzumab at a dose of 1,000 milligrams on day 1. And only 1 week later do you start the treatment with glofitamab. Now, why was obinutuzumab administered first? That is because if you have a reasonably high tumor bulk, then if you use glofitamab directly, you're going to have a lot of toxicity in terms of CRS. And therefore, to reduce the tumor bulk to a certain extent, one uses obinutuzumab initially, and then you used step-up dosing of glofitamab, wherein first you use 2.5 milligrams. A week later, you go up to 10 milligrams, and another week later, you go up to 30 milligrams, which is the full dose. And cycle 2 onwards, you then give glofitamab. So, what were the results? So, these were the characteristics of the patients. The median age of 66. Most of them were advanced stage 4 disease was the majority, and DLBCL was the predominant malignancy. Most of the patients, at least half of them, had bulky disease. Many of them had more than 3 prior lines of treatment. And most interestingly, there were about 33% patients who had received prior CAR T cell therapy. Some of them had received ASCT. And look at this refractory disease. So primary refractory, about 58% patients. Prior to refractory to CAR T cell therapy, so 30% of patients were refractory to CAR T cell therapy as well. and also to any other anti-CD20 antibody. Let's look at the results of this study. So the PFS by cycle 3, okay, this is the PFS probability after cycle 3. And at 18 months, you can see for those patients who had a CR, it's about 72% chance that they're going to stay without progression. Whereas if you have a PR or a no response, then it immediately dramatically goes down. So that's the importance of achieving a CR with these drugs. That's the overall survival at by cycle 3, again, about almost 80% for those who have achieved a CR. The best response, so ORR was about 51%, the CR was about 40% patients achieved a CR. And the duration of the CR was about, the median was 18 months, and 26 months was the duration of the CR. Now for the subgroup, in the subgroup analysis, post CAR T cell therapy, 35% patients achieved a CR. So that is very interesting that, patients who have had CAR T cell therapy and are refractory to it can still achieve reasonably good, in a good number of patients, they can achieve a response with a bispecific antibody. What about the CRS and the other, the CRS in general? So most of the patients will have some sort of a CRS. The use of corticosteroids and tocilizumab is there in about 1/3 of patients. And as you can see here, majority of the patients will have a CRS in the first doses. So the 2.5 milligram dose is going to cause the maximum incidence of CRS. And as we go down the order, you see that the CRS incidence, despite increasing the dose of the medication, the CRS incidence is going down, and later on it's almost nil. Now, so that was the data with the single agent glofitamab in DLBCL. What about the data? Is glofitamab being used in combination with other drugs? So now you can see a lot of trials, a lot of publications, smaller publications, which don't have very long-term data, but a lot of studies are ongoing with use of glofitamab in earlier lines of treatment and in combination with chemotherapy or other immunotherapy drugs. Now, since we don't have the time to discuss each of these trials, I'm just going to discuss one important trial, the STARGLOW trial, which was in patients with RR-DLBCL, who had more than one prior line, or at least one prior line of treatment. And in this, glofitamab with GEMOX regimen, the gemcitabine oxaliplatin regimen, was compared with rituximab GEMOX. Right, and the same kind of dosing was there, step-up dosing in cycle 1, and then from cycle 2 onwards, the whole dose was given of 30 milligrams, and as compared to the standard GEMOX, along with the standard GEMOX regimen. Now, these were patients who had, as I said, at least one line of therapy in the past and relapsed or refractory disease. Here, the primary endpoint was overall survival, and the secondary endpoints were PFS, CR rate, duration of CR. These are baseline characteristics, again, kind of standard stage 3, stage 4 disease in the majority of patients, primary refractory in at least half the patients, bulky disease in a good number of patients, and the cell of origin actually never mattered in all these bispecific antibodies, as you may realize. The cell of origin is immaterial as it is in CAR T cell therapy, where it doesn't matter what the cell of origin was. So many of the patients had, some of the patients had received prior CAR T cell therapy as well. And in this study, you can see, if you compare this is the glofit GEMOX versus the R GEMOX, you can see a clear improvement in the PFS as long as 30 months. And you can see the curve nicely flattening here, showing, sort of kind of excellent results with this particular regimen. That's the CR rate. You can see almost more than double the incidence of CRs with the glofit GEMOX as compared to R GEMOX. And the overall survival also distinctly better with glofit GEMOX. And that's higher than almost close to 60%. Okay, so that's the overall survival median. You can see glofit GEMOX, it's 25 months as compared to only 12.9 months here. So that was with glofitamab. Next, we come to epcoritamab. So So epcoritamab monotherapy in patients with relapsed or refractory follicular lymphoma. So I told you epcoritamab is approved for follicular lymphoma as well as DLBCL. And in this study, this is the phase 2 cohort of a single arm multi-center study. I'm going to discuss just this in just brief. Most of the patients who were relapsed refractory follicular lymphoma, grade 1 to 3A. And I won't go through this slide, but I'll just show you that what the results are. You can see the PFS in this cohort of patients was about 50%, as you can see here for the entire cohort. But if you had achieved a complete response, then your PFS was much, much higher, as you can see, as compared to those patients who had not achieved a complete response. And for those patients who had MRD negative disease, again, excellent results as compared to those who were not MRD negative. And that's the overall survivals. The overall response rate was 82%, with 62% of patients having achieved a complete response. So excellent results for follicular lymphoma, refractory disease, or relapsed disease with epcoritamab. How is epcoritamab dosed? So in follicular lymphoma, it is given as a step-up dose, wherein on day 1, you give 0.16 milligrams, day 8, you give 0.8 milligrams, day 15, you give 3 milligrams, and day 22 onwards, you give the full dose, which is 48 milligrams of epcoritamab. And cycle 2 to 3, you give the 48 milligrams on day 1, 8, 15, and 22. For cycles 4 to 9, you give the dose on days 1 and 15, as you give, instead of weekly, you're giving it bi-weekly now. And from cycle 10 and beyond, you give it every 28 days. In DLBCL, the step-up dose is from day 15 onwards, it is 48 milligrams instead of the day 28. So you just kind of escalate the dose a little higher earlier when you're using it for DLBCL. That was so the previous one was for follicular lymphoma. Now, what about epcoritamab in DLBCL? So in DLBCL, third line treatment, third line or beyond. This is a pivotal stage phase 1 to 2 study in patients with RR large B cell lymphoma who had at least 2 prior lines of treatment. And again, most of the patients had received more than almost 4 lines of treatment. Many of them had primary refractory disease, refractory to the last line of treatment, refractory to 2 consecutive lines of treatment. Some of them had prior ASCT and relapsed within 12 months after ASCT. Prior CAR T cell therapy, in about almost 40% patients had prior CAR T cell therapy. Progressed within 6 months of CAR T cell therapy, almost 75% of them had progressed beyond early after CAR T cell therapy. In this study, what were the responses? So the best overall response. The CR was achieved in 61% of patients and a PR of 30 in 38. I'm sorry, a CR was achieved in about 38% patients and a PR in about 24% patients. So you see the PFS somewhere close to around 40% is what one can say. So now this was in can you improve on the monotherapy with epcoritamab? So a lot of studies have been ongoing with where you're combining epcoritamab with other agents, and in this epcor NHL5 study there are almost 7 arms, and in arm 1 there was epcoritamab plus lenalidomide, arm 2 there's epcoritamab plus ibrutinib plus lenalidomide, arm 3 polatuzumab plus RCHP and epcoritamab. Then there is another CELMoD in addition to epcoritamab, and in the others there is ibrutinib plus or minus venetoclax. So it's been tested in a large number of with addition of a large number of drugs and multiple cohorts. But just to show you the arm 1 of this study, where epcoritamab was combined with lenalidomide, in this particular cohort, again, the inclusion criteria, the distribution of patients is somewhat similar to what I had mentioned in the past. And here the ORR was 71.9% with a CR of 53%. So you're kind of improving on the efficacy with addition of lenalidomide. And across most of the subgroups, you can see whatever the cohort was, the results were kind of similar. In terms of safety, uh, it was kind of similar to glofitamab. Cytokine release syndrome was seen in a reasonable number of patients, but it was mostly very low grade and easily manageable. Just to combine glofitamab, to sort of combine the data and trying to compare these two drugs. Although this is not the best way to compare any two drugs, this is not head-to-head comparison, but just to give you a glimpse of how it is, epcoritamab and glofitamab. So that's glofitamab, the overall response rate of 51%, epcoritamab about 63%, CR similar, median duration of response 26.9 months, 15 months with the epcoritamab, median PFS 12 months, median PFS lower at 4.4 months, median time to CR 43 days and 2.7 months, which is almost the similar. CRS incidence, again, grade 1 in majority. ICANS, very, very minimal. With bispecific antibodies, the incidence of ICANS is much lower than that with CAR T cell therapy. Cytopenias is manageable. Often neutropenia is the more important thing, but often reverts quickly with the GCSF. And serious infections only in a minority of patients. Okay, now the important thing is how long do you, when you start these drugs, how long are you going to continue them? So what is the duration of bispecific antibodies in lymphoma? So the factors determining duration would be the type of bispecific antibody that you're using, the lymphoma subtype, the treatment response, and tolerability and toxicity. But in general, epcoritamab, where you're using it for RR-DLBCL after more than or equal to 2 lines of treatment, you're initially using it weekly, then bi-weekly, then monthly, as I had mentioned earlier. And the duration is you continue it until progression or toxicity. So the label is that you just keep continuing it as long as you feel the patient is not having toxicity, as long as the patient is responding. And in the real world, most of the times, patients have continued it for more than 1 year. Whereas when it comes to glofitamab, where the indication again is RR-DLBCL after at least 2 lines of treatment, the duration is fixed. So when you're using glofit, in general, you're going to use it only for 12 cycles. That is 12 cycle course. So the treatment ends after 12 cycles, regardless of the response. So even if you had a complete response, unlike epcoritamab, it is glofitamab, you stop it after 12 cycles. And you would note that the duration of the response, the responses are significantly durable even after you stop it. So as you saw in the study, you've given it for 12 cycles and you've stopped it, but even at 30 months, the responses are continuing to go on, and the curves are absolutely plateauing. So you may not have to give continuous response, and that is very important because these drugs are exorbitantly expensive. Mosunetuzumab, the indication is relapsed refractory follicular lymphoma. If you have a CR, then you can stop after 8 cycles. And if you have a PR or a stable disease, you can continue up to 17 cycles. That is what the label says. Again, it is a time-limited therapy with mosunetuzumab. Plamotamab is still in clinical trials, typically continued until progression or toxicity, and the duration varies according to trial protocol. This drug is still quite new, and we don't have much of data on this. So the summary of the duration of treatment: epcoritamab until progression or toxicity, glofitamab 12 cycles, fixed duration, mosunetuzumab 8 to 17 cycles, depending upon the response, and plamotamab is trial dependent. Right now, the all important question is, are bispecific antibodies providing a chance for cure? Is the million-dollar question, and the answer is not yet very clear because we are, this is a very, very evolving field. There's a lot of emerging data, with these agents alone or in combination with other drugs. So the data is going to keep changing, keep evolving, and we don't know the answer yet. But just to show you, look at these curves. Glofitamab, as I said, you give it for 12 months, but the responses are going beyond 30 months, and we don't know what's going to happen in future. Whether these patients relapse or actually are cured is something that needs to be seen. Similarly, with epcoritamab, kind of similar findings in DLBCL. A good number of them who have achieved CR are continuing to show a long-term response. And the characteristics of these patients, including post-CAR T failure, right? So these are some of the updated results at ASH 2024, just showing you the kind of number of publications that are there on this. So the fixed duration of glofitamab monotherapy continues to demonstrate durable responses in patients with RR DLBCL, 3-year follow-up from a pivotal phase 2 study. This is the 3-year update from the EPCOR NHL1 study. Epcoritamab leads to deep and durable responses in RR large B-cell lymphoma, and long-term efficacy of odronextamab, which I didn't discuss much, in RR DLBCL, pooled analysis of the ELM1 and 2 study. So all these drugs are kind of having similar efficacy is what I would say, what I gather from the data that I've gone through. So let me just discuss this case with you. This is a 72-year-old lady who's a diabetic. She had DLBCL, bulky disease, GC type, non-double hit subtype. She was treated with R-CHOP initially, and she tolerated the treatment very poorly. You know, she had kind of severe neuropathy and various other complications, infective complications, etc. Didn't tolerate it very well at all. But she achieved a CR on PET after R-CHOP, and now has relapsed in 12 months' time. At 12 months, she has relapsed with a bulky disease again. She's unfit for autologous stem cell transplant. And so the question is, what line of treatment are you going to follow, right? How are you going to treat this patient? What are the options you have? Naturally, you have the option of CAR T, you have the option of bispecific antibodies, you have the option of going for palliative care, and you have the option of giving some other combination. So the question is, should she go for bispecific antibody alone, or would she go for CAR T? The age-old, not age-old, the kind of the latest debate upon whether CAR T is better or bispecific antibody is better. And everybody, all the companies that are manufacturing bispecific antibodies, whether it's lymphoma or myeloma, they keep arguing whether, CAR T is going to decrease the market for bispecific antibodies and vice versa. But I always say that I don't think that, these are actually these are synergistic treatments. They are they are to be, both the treatments are equally good, and they are complementary to each other. They are not each other's enemies or each other's competitors. So should you go for bispecific antibody alone or for CAR T cell therapy? Now, just to give you a perspective, what is the cost of glofitamab? Currently, if you import it, it's not yet licensed for use in India. Hopefully that time there'll be a patient assistance program. But currently the cost of glofitamab, if imported, for about 10 milligrams is 6 lakh rupees. And about 30 milligrams is about 13 lakh rupees, right? So if you're going to give this drug in 12 cycles, that's going to be 13 into 12, right? So it's an exorbitant cost. And therefore this patient obviously, and most Indians will not afford these drugs. Currently, bispecific antibodies are approved for 2-line failures. Now, of course, you can argue and you can say you can go off-label and use it for 1-line failure also. It's up to you, but with patient, with the consent. But currently, they are approved for 2-line failure. This patient has technically had only 1-line failure. So logically, she plans to go for CAR T cell therapy. Right, she's going to go for the Indian CAR T cell therapy, which is pretty standard now. We used this several times, and we're pretty used to doing CAR T cell therapy. So she's going to go for CAR T. So the important thing is she has bulky disease. So you need to get the disease down to a significantly low level before you're going to do a CAR T cell therapy, preferably a PET negative disease. The better the pre-CAR response of the tumor, the better your response is going to be. Now, the question is, how do you bridge her and get that disease down, right? She refuses chemotherapy because she's had a horrendous time with just R-CHOP, so anything else is kind of out of question, right? So how are you going to bridge her? So the latest thing is bispecific antibody-based bridging therapy. So we've planned for a polatuzumab plus rituximab on day 8, which is already received, and then glofitamab on day on day 8, we're going to give glofitamab in a step-up dosing of 2.5, then 10, and then 30 milligrams. And then after 1 cycle, we plan to do a PET scan. Or typically in literature, most people will use glofitamab for about 2 to 3 cycles before they go in for CAR T cell therapy to achieve better responses. But we've seen in the past that you can have responses as early as with 1 cycle, and more important than that, you're going to save almost more than 13 or 26 lakh rupees if you're going to go in for if you try and save the next cycle. So therefore, what we do many times is to just assess the response after 1 cycle, and if you achieved a reasonable response, then one can directly go for the CAR T cell therapy. So now there's a few caveats to bispecific based bridging therapy. The PET scan should be done 4 weeks after the last dose of bispecific antibody, right? And that's the reason. The reason is obvious, that you want to prevent this pseudo progression, that because because the tumor is, because you're activating T lymphocytes, you're going to have a inflammatory response inside the tumor. You could have a falsely positive PET scan, and therefore you've got to leave about 4 weeks after the last dose of glofitamab before you do the PET scan. Now, the harvesting of the T lymphocytes for CAR T should ideally be done before bispecific antibodies has been administered. So right now, when you've decided to do the CAR T, even before you've given the glofit, you've got to first do the harvest, prepare the CAR Ts, freeze the CAR Ts, and keep them, and then start your bridging, etc. So this is basically to avoid collecting cells that may be exhausted or impacted by the bispecific antibody. So when the bispecific antibody activates T lymphocyte, it kind of exhausts them and may impact them. And those are not the cells which you want to collect and send for your CAR T preparation, right? You want cells which are reasonably naive. Now, the problem with this is that if you kind of harvest the cells in advance and then send them for CAR T production, and if for some reason the patient is not able to do a CAR T cell therapy because some complication happens in between, then the huge amount of money that you're going to spend for your CAR T is already gone, right? So it's almost 35 lakhs of rupees that you need for preparation of the CAR Ts, and that money is going to go if you don't reach the CAR T. And therefore, most of us have been a little sort of conservative, and we prefer to first give the bridging, get the disease down, be sure that the patient is actually in a fit condition to undergo the CAR T, and then only do the leukapheresis. So the last dose of the bispecific antibody should have been given at least 2 to preferably 4 weeks before the lymphodepletion, right? Because bispecific antibodies can cause prolonged T cell activation and cytokine release, and you may have this risk of overlapping toxicity, right? So the bispecific antibody may worsen the CRS and the ICANS if you give the glofit now, and very soon you do the lymphodepletion, the CAR T cell therapy, you might have overlapping toxicity, and therefore you've got to leave at least a 4-week gap between these. If the leukapheresis cannot be done before bispecific administration, then leave a gap of 4 weeks after the bispecific. That's what I just mentioned. I hope this is clear. So what would be the treatment algorithm for second-line large B-cell lymphoma? So if you look at the time from first-line therapy, right? So you give an R-CHOP and the patient has relapsed after R-CHOP. Now you've got to look at whether the patient has relapsed within 1 year or more than 1 year, because that's the time we know that if it's less than 1 year, you're going to try CAR T cell therapy. And we know that 75% of patients will relapse within 1 year if they have to, and about 25% of patients will relapse beyond 1 year. So if it's beyond 1 year relapse, you've got to look for whether the patient is eligible for ASCT. If it is, of course, you've got to go for a second-line salvage followed by autologous stem cell transplant. That's what we've been doing for the years. And about 50% of patients you're going to be able to cure with autologous stem cell transplant in this setting. But that accounts for about 5% of all second-line DLBCLs, who will fulfill all these criteria. Now, if you relapse less than 1 year, you're going to look at whether the patient is CAR T eligible. Yes, you've got to do CAR T cell therapy, and about 40% of patients who undergone CAR T cell therapy are going to be cured even with the Indian CAR Ts. And that's going to be about 20% of all your projected cures for all your second-line DLBCLs. For the entire cohort, about 20% patients will be eligible for all of these. But then you've got a huge other sort of, almost 70% patients who are not going to be eligible either for CAR T or not, for ASCT. And those patients or those who failed these treatments, the CAR T or ASCT, And then that falls into these in this category where you've got investigational regimens, polatuzumab BR, tafasitamab lenalidomide, and then here comes the antibodies. This is an important role, the current sort of place of bispecific antibodies. So first, you're going to look at whether ASCT or CAR-T, and if not, then you're going to go for bispecific antibodies. The other role is going to be as a bridge to CAR-T. So these are the two indications currently for the use of bispecific antibodies. What are the barriers to CAR-T cell therapy? This is kind of common. We know this. We've discussed this multiple times in multiple myeloma. The financial burden, the insurance coverage, knowledge gaps and safety of CAR-T cell therapy. This is gradually improving. A lack of understanding of the AE management for referring physicians, late referral for CAR-T cell therapy, patient hesitancy for the treatment. There are patients who, this particular patient, of mine that I described, she is hesitant for CAR-T cell therapy, is scared of the CAR-T cell therapy. She knows there's chemotherapy before that. So she's worried about it. She would prefer to take a subcutaneous drug, given a chance. The patient disease burden causing ineligibility. So, as I said, you've got to get the burden down somehow. Requirement for travel to treatment centers, all these are kind of have been barriers to CAR T cell therapy, which of course are currently improving in general, at least in our country, but they are barriers all the same. So just to conclude, the current landscape is that there's existing therapies like autologous transplant and CAR T have limitations in eligibility and efficacy. There are barriers, significant logistical and patient-specific challenges. Not everybody can do a CAR T cell therapy. There are only few centers across India who do CAR T cell therapies regularly and have the know-how for it. Whereas the drug is something which you just need to give subcutaneously. So obviously it has widespread adoption. Emerging options, there are new therapies, including bispecific antibodies, like all the ones which we mentioned. And ongoing research is crucial to redefine treatment algorithms and address long-term side effects. So you've got to how best to combine these bispecific antibodies with existing therapies, including chemotherapy, is a matter of hot ongoing debate. A lot of trials to address this issue, including in first line. And since there is no mature data available for any of these trials, I have not covered them in my lecture so far. So this is an interesting, very, very interesting concept. What could be the future? What is going to be the future? Already studies are ongoing with this, right? So let me tell you one thing, that bispecific antibodies are not used as maintenance therapy after CAR T cell therapy. So for those patients with CAR T who achieve a response but lose their B cell aplasia early, these are the patients who are likely to relapse early. Or if you've not achieved a CR with CAR T cell therapy, then that becomes a major area, sort of an area where we don't have any answers. How to improve the efficacy of the CAR T? How to make that CAR T how to activate that CAR T and make it kill the tumor cells? That is something which we really don't have as of now. And what is being tried is where it's a CAR BiTE. These are CAR T cells that can secrete a BiTE antibody. They have been sort of primed or to secrete a BiTE when they get activated. So you have the CAR T cell here, and that's a single chain variable fragment here, and it is actually secreting the BiTE. So it is kind of the BiTE is bridging the CAR T with the tumor cell and making so it's like a bispecific antibody which is binding the CAR T with the tumor cell and trying to enhance the efficacy of the CAR T in addition to its single chain variable fragment. So that's what shall I say, a dual sort of weapon that might happen in future. And just to end my talk, so I just thank you for a patient listening, and I hope this looks like a car that is armored with a BiTE. So this looks like a car BiTE, I thought, and that's why I put this picture. Thank you very much.
Thank you, sir. Fantastic talk. Wonderful to listen to you. What a clear concept. That was brilliant, sir. Thank you so much, sir. And I request now all our discussants to please put the hand raise sign so that you can start our question and answer session. Yes, we have first Dr. Rajat Bhattacharya, sir. Sir, please, your question, please.
Fantastic talk. the last slide was the most interesting to me. So taking that into account, can you explain how this T cell activation is persisting even if you stop the medication? And like blinatumomab, once you stop it, it's supposed to stop working. T cell activation should not.
Yeah.
But you're seeing the persistent response. I mean, what is the mechanism that their T cells are activated and they're still working?
No, it is not that they have active that they are continuing to get activated. Once the half-life of the antibody, which is typically about 3 weeks, is gone, the antibody has already gone off from the circulation. The responses that are persisting are because you achieve that kind of a deep response, a potential cure that you kind of wiped out the last tumor cell. That is the way the response continues. It's not that the bispecific antibody is going to continuously activate the T cells. And that I thought is very encouraging because this continuous treatment is something which is absolutely financially a huge challenge. So a fixed duration response wherein you have a long-term disease-free period is something very encouraging. And there have been studies which I didn't have the time to show, but retreatment with the glofitamab after the initial break. So supposing you've given for 12 cycles and subsequently the patient has relapsed after a certain period of time, you can re-challenge and still get a good response.
Any other question, Dr. Rajat Bhattacharya, sir? Fine. Anybody has any other question? Yes. Yes. Yeah. So please go ahead.
Dr. J.M. Kungar. Thank you, sir. It was a nice talk. I just want to ask whether the effectiveness of this bispecifics in view of the side effects of cytokine release syndrome and in view of neurological toxicity, how do you look in the future towards the effectiveness of these bispecifics?
So actually, sir, as compared to both in myeloma as well as in lymphoma,
because we have to admit the patient in view of cytokine release. We have to admit the patient.
Yes. So you have to
for cytokine release syndrome.
Yes. So you necessarily should admit the patient. And in general, the higher the tumor burden, the more the chance of CRS. So you must admit the patient and observe the patient for about 1 to 2 days, at least for about 48 hours. The admission should be done for the first dose at least. Subsequently, you may not admit the patient. But then, in general, the CRS has been much lower with bispecific antibodies than with CAR T-cell therapy, both for lymphoma and myeloma. So it's not a big challenge to manage it. Tocilizumab very effectively mitigates the CRS. And ICANS is almost never a concern with bispecific antibodies.
You think it can be managed easily?
Yeah, they can very well be managed. I mean, they're pretty easy to use, and it can be managed at a smaller center also.
Thank you.
Thank you, sir. Dr. Aditya.
Good evening, everyone. Thank you, sir, for the wonderful talk as always. So I have two questions for you. So first one is, as you mentioned, like achievement of CR is very, very crucial when we are treating these patients with bispecific antibodies. What would be your approach towards patients who achieve a PR? Let's say after 2 cycles or 3 cycles, would you continue to wait or change therapy, and at what point?
Yeah. So if you've achieved a PR, generally most of the times the responses are going to happen by somewhere around cycle 3. So if you use it for that much of time and you achieved a PR, then you're sure that the patient is not going to respond any further. And in that case, you probably got to do something else. Either if the response has been reasonably good in the sense that that you achieved something like a 80-90% reduction in the tumor burden, then you could probably go for CAR T straight away, or then you've got to change your line of treatment and then try.
Sir, my second question is like regarding the role of chemotherapy drugs in patients who are primary refractory DLBCL or early relapse within a year. So let's say someone who has progressed or who is refractory to R-CHOP So is there any role of actually chemotherapy in future treatments, let's say second line or third line? The context for this question is like whether to use glofitamab in combination with Gemox or glofitamab in combination with Pola and rituximab for the second line or later onward. Is the question is like, should we completely rule out the possibility of using chemotherapy if somebody is primary refractory?
No, you cannot rule it out completely, but we know from you, I'm sure you also have this experience that, if somebody who's not budged at all, those patients may budge a little bit with the different chemotherapy, but they generally don't achieve excellent responses. So that primary refractory DLBCL is a huge, need gap where you need something beyond chemotherapy. And there, yes, you can very well use polatuzumab. In fact, Pola and glofitamab have been, that's like a very kind of a hot favorite regimen that's emerging now from MSKCC and MD Anderson trials are ongoing with Pola rituximab plus Pola plus glofitamab. That's another favored combination. So you can try polatuzumab with chemotherapy if you can. Otherwise, the ideal thing to do now would be to use one of the bispecifics with or without chemotherapy, depending upon the tumor bulk. If you've got a very large tumor burden, then you may want to add on some chemotherapy that's not going to cause too much of toxicity. The idea is to just kind of get a reasonable response. But there, I think largely you've got to use either an ADC or a bispecific antibody.
Thank you, sir.
Thank you, Dr. Aditya. Dr. Gopinathan?
Good evening, sir. Thanks for the lovely talk as always with a lot of insights. So my query is, what is the current role of bispecific in mantle cell lymphoma space?
Yeah. So I didn't cover the mantle cell lymphoma so much, but yes, I mean, bispecific antibodies have been used very well in mantle cell lymphoma with pretty good results. Epcoritamab has been tried, glofitamab has been tried, odronextamab has been tried for MCL, and now where to use it in the algorithm of mantle cell lymphoma is still an ongoing debate. But yes, in the indications that I just mentioned for other lymphomas in MCL as well, these drugs have been used.
And you're talking about the persistence for like those who are losing B cell aplasia, kind of a post-infusional bispecific. So is there a role of lenalidomide or immune checkpoint inhibitor post-CAR T for the persistence of CAR T or efficacy of CAR T?
So that's as I told you, that's a very what shall I say, a large it's a need gap. We don't know how best to deal with those patients. If you ask me personally, what we've done, we've used nivolumab in that situation, and there've been some publications on that as well. But I don't think that it's a very effective way of activating CAR Ts. If CAR T has done the job and achieved a CR, then everything is good. If you haven't achieved a CR, then it's a big problem. Or if you're losing the B cell aplasia, you can add lenalidomide, you can add nivolumab. Definitely not bispecific antibodies. So far, at least they've never been tried in that situation. But most of the times, one uses nivolumab at lower doses.
The last question is a real life scenario, sir. I have a 66-year-old gentleman, reasonably fit, had relapsed DLBCL after a period of 10 years. He had initially had, way back 10 years, he had a hepatic DLBCL, but now he has the disease primarily in the paraspinal compartment and leptomeningeal enhancement. Now, how should I be approaching this patient? But he has a residual paraparesis because of the disease. He has a residual paraparesis. Now, how should I be approaching this patient?
So in this patient, since it's a late relapse, of course, it's a different clone. It's not the same disease that was there in the past. So it's a different disease, and the biology of this disease may be completely different. One never knows. But because of the fact that it's a late relapse, this patient, I would first go with the salvage chemotherapy. Depending upon how bulky it is and whether he's in a fit condition, etc., one would go for a salvage chemotherapy, along with of course you're making sure that the chemotherapy also penetrates the CNS. Hydros methotrexate, or whatever protocol you decide to choose, along with triple intrathecal therapy, radiation. And if the patient achieves a CR, then one would go for an autologous stem cell transplant. That would be my first approach. In the event that the patient has not achieved a complete response, then alone one would consider other therapies. But one must note that the bispecific antibodies probably are not the best drugs for CNS disease, not the best drugs for that. CAR-T, yes, can penetrate the CNS, and that should be the aim probably in case the patient is not suited for a autologous stem cell transplant. In autologous stem cell transplant, if you're doing, try and use TEAM instead of BEAM, that's thiotepa instead of BCNU.
So he still has some degree of residual paralysis. He still comes in wheelchair. Like he has now attained that remission. So what would be the best way to consolidate at this point of time? Like if he has that.
So that becomes a challenge, when you're doing an autologous stem cell transplant, somebody who's paraparetic, and here I think there's no clear answer. The patient's wishes, the family's wishes must be taken into account, and then only you've got to proceed.
Thank you. Thank you, sir.
Thank you, Dr. Gopinath. Dr. JP Meena.
Yeah, good evening, sir. This is Dr. Jagdish Meena from Delhi. I'm pediatric oncologist. So thank you for excellent talk. So I have few questions. So as per your experience, particularly for our developing country like India, so what would be the future of CAR or CAR bite in particular in our country? Or would it replace totally transplant, and would it be cost effective compared to the transplant?
It's surely not cost effective as compared to the transplant. There's no comparison within the cost at all. But we've got to remember that autologous stem cell transplant is best suited for patients who have had a slightly later relapse as compared to somebody who's relapsed very early or is refractory. That's the situation where you want to do CAR-T and bispecific antibodies. Currently, the cost has to be lower. Otherwise, it's absolutely unmanageable unless there's a good patient assistance program. The bispecifics would probably be more expensive than what CAR-T is currently priced. The CAR-T cost is not going to go up in India. The CAR-T cost is going to reduce in India as more and more CARs come. Hopefully, the technology will also be better. So CAR-T distinctly has a bright future in our country. And as regards bispecific antibodies, it has its own place. As I said, currently it is more suited for those patients who are CAR-T, who are relapsed post CAR-T. As I mentioned in the talk, almost 30 to 40% of patients who have relapsed after CAR-T therapy will respond to bispecific antibodies. And then you could decide whether you could actually do an autologous or an allogenic transplant. We have not touched upon allogenic transplant, which is a very, very important modality of treatment. In good hands, an allogenic transplant can cure really bad lymphomas. So that must never be forgotten.
Yeah, thank you, sir.
Thank you, Dr. Meena. HMDT. Yeah, somebody with the name HMDT.
Sorry. Yes, I'm Dr. Tanda from Myanmar. Thank you for your lecture, sir. I have two questions. When the patient is eligible for both types of therapy, how do you consider to choose between CAR-T and bispecific antibody?
So it's a good question, actually. It's a very good question, particularly because of the kind of situation where we are in right now. We don't know what the really long-term data with bispecific antibodies is, whether they can act. So we know that CAR-T will cure roughly, let's talk about DLBCL or follicular lymphoma, where the results are the best. Somewhere between 40-50% of patients who have relapsed, you're going to be able to cure them with a CAR-T cell therapy. Now, whether the curves that I show are flattening somewhere around 30-40% patients are surviving at 3 years. Whether bispecifics can also cure them is what we don't know. So general thought process is that they're going to sort of give a durable response, but probably not cure. And therefore, one would always want to, in anybody who's eligible for CAR-T, that's the first treatment that you must give. And bispecific would be only after CAR-T, or if you're not eligible for CAR-T.
Oh, thank you, sir. And how can we predict the response of the bispecific antibody?
Currently, there is absolutely no way of knowing how which patient is going to actually respond. Whether it's CAR-T or whether it's bispecific antibodies, it's very difficult to predict which patient is actually going to show a response. Surely, our traditional criteria, the cytogenetic changes, the cell of origin, all those parameters just go out of the window when you come to immunotherapy.
Thank you, sir.
Thank you. So there are some couple of questions from the audience. The first question is from Dr. Mehak Trehan.
One more question I want to ask.
Yes, please go ahead, sir.
One more question, sir. Whether
Yes, please go ahead, sir.
tried this chemotherapy along with bispecifics, or have you tried monoclonal antibodies?
I have used to be as I mentioned right in the beginning of my talk, I have used glofitamab only in 2 patients so far. Okay, so my personal experience is limited. Whatever I have is just knowledge, theoretical knowledge. But as I told you, chemotherapy is being combined very much with these bispecific antibodies, particularly in earlier lines of treatment, and also with polatuzumab. So there is a logic and a rationale for combining both these therapies, and it has been shown to be additive rather than the other way around. As I showed you the data of epcoritamab, it's being tried with so many other drugs, venetoclax, ibrutinib, lenalidomide, everything is being tried. We are yet to see the long-term results.
Thank you.
Thank you, sir. Dr. Aditya.
Sir, I want to ask you regarding relapsed Burkitt's lymphoma. I asked you a similar question a few weeks ago. So, in the context of bispecific antibodies, again, do you feel is there any role of bispecifics in Burkitt's lymphoma?
To the best of my knowledge, currently, no. They have not been tried in Burkitt's lymphoma. We don't have adequate data on that, so I wouldn't use it for relapsed Burkitt's.
Fine. Thank you.
Thank you, Dr.
Also for CLL, it's not a good disease to treat. Richter's, no.
Thank you, Dr. Aditya. We'll take some couple of questions from the audience. Dr. Mehak Trehan has a question. With Roche likely bringing glofitamab in the Indian market, do you foresee it replacing polatuzumab-based regimens as a preferred option in post-second-line DLBCL, especially for patients who are autologous stem cell transplant ineligible or post-CAR T failure? And in your practice, which patient groups would you prioritize going for glofitamab once it becomes easily available in Indian market?
Well, yeah, you would ideally want to go for a drug that is more powerful and more likely to get the patient into in remission. And we know that currently polatuzumab is not a drug which is going to give the kind of response that glofitamab would do. But yes, I mean Pola Rice. So the Pola BR, in my opinion, is one of the, what shall I say, although it's FDA approved, in my opinion, it's a rubbish kind of a combination. You're not going to cure a DLBCL with Pola BR. You're going to palliate them, an expensive palliation. So Pola with rice and Pola with some of the other salvage chemotherapies is being tried with good data. We've also tried it. So that's the regimen that I would use, maybe Pola rice, if I were to use polatuzumab in a second line setting. And when it comes to glofitamab, yeah, surely, I mean, maybe Pola with glofitamab is also going to be an excellent combination. They're going to be additive and synergistic. And otherwise, between the two, if you ask me, yes, the data is better with glofitamab. I don't know what Roche wants.
What about Pola or Gmox?
Pola R-Gemox, yes, that's again a good regimen. I mean, as I told you, Pola in combination with anything else, any other regimen is can be kind of curative in a certain number of patients. So it can very well be tried.
So if the patient has not worked with Pola BR because it is a rubbish regimen, so can it be cured with Pola or Gmox then after?
Because Pola BR again, you're going to not be able to do a CAR T after that. So I don't think that's the regimen that should be favored unless you clearly have a palliative intent in mind.
Yeah. So I think for salvage, best would be Pola or Gmox,
sure,
or Pola or ice.
Sure.
Another question which has come from Dr. Emon Tent. Any experience of bispecific in transformed B cell NHL?
In transformed B cell NHL, what would that mean? Is it follicular with histologic transformation?
Follicular with histological transformation too.
Yeah, so that is absolutely a clear-cut indication for bispecific antibodies that mentioned even the eligibility criteria for glofitamab and epcoritamab transformed FL. was one of the situations where it was used. It works as well.
Perfect. Another question he has is your experience of management in low-grade B-cell NHL with transform to 10% lymphoblast.
Transform
B-cell
to 10% lymphoblasts.
Yes.
Well, I
the
am not
body
sure
has
what.
10%
I have not
B-cell
heard of
lymphoblast. Then
a
this becomes
follicular transforming
ALL.
into an ALL. So I
ALL.
don't really know what the answer to that is.
Another question, sir, is from Dr. Raghavendra Rajesh Workar. What toxicities would you like to expect when you go for epcoritamab continued beyond the fixed duration?
Predominantly T-cell exhaustion and in actually secondary infections. So some of these drugs are not devoid of infections, and because you're going to constantly activate T-cells and exhaust them, you can actually have secondary infections also. So that's the important thing. And apart from that, for long-term per se drug toxicity, I don't think there's going to be anything.
Yes, sir. Thank you, sir. Another question is when we think of combining chemo with bispecifics, why can't we think of combining multiple bispecifics?
Of course, multiple bispecifics, that's difficult because the CD20 is going to be, the competing. They're going to compete with each other. Both the targets are the same. So although the epitopes are different, but I'm not sure whether that's a wise idea.
Thank you, sir. Another question is from Dr. Suthanthira Kannan. Any basic regarding the biological reason behind administration of epcoritamab indefinitely?
I really don't know. That's the way it's been designed, but I'm hoping that ultimately they come up with a regimen that is time limited.
Thank you, sir. Another question is from Dr. Hitha B. Your experience regarding the role of CAR-T in primary mediastinal B-cell lymphoma?
Pretty much useful. I mean, it is we've done it also in the past, and even in all the clinical trials, PMBCL is very much an indication where CAR-T has been tried, and it works pretty well, as well as DLBCL.
Thank you, sir. Another question is from Dr. Raghavendra Rajesh Workar. Instead of using rituximab before glofitamab, can we start glofitamab at a dose of 1 mg because sometimes the disease can be resistant to rituximab?
So yeah, that's a good question. And actually, not rituximab. The drug is obinutuzumab that has been approved for this purpose. But you could even use rituximab if the patient has a sensitive disease. And there was a poster. I mean, an oral presentation where at ASH, I think, where the obinutuzumab was done away with. And just glofitamab without anything else. As in epcoritamab, you don't use a anti-CD20 antibody before. You don't use rituximab or obinutuzumab before epcoritamab. It is only the way sort of when they decided to use it for clinical trial, that's the way they designed it for glofitamab, and that's the way the label is stuck on. But in this particular trial where they compared glofit with and without obinutuzumab, there was no difference. So the question is right. It's possible that glofitamab could work very well alone.
Thank you, sir. Another question from Dr. Akansha Garg. In patients who have been exposed to bispecifics, will there be any effect on allo stem cell transplant outcomes afterwards?
Allogenic transplant, yeah. So you've got to give a wash off period after if you plan for an allogenic transplant instead of a CAR-T. You've got to give a wash off period of minimum 4 to 6 weeks. Allow the T cells that have been activated to sort of calm down, and then only start your conditioning regimen. But if you ask me would there be any difference in the outcome? Surely not.
So this can be both for bispecific and CAR-T both.
Bispecifics and CAR-T both. Well, yes. So prior CAR-T would again not be at all always very. In fact, CAR-T is often used as a bridge to allogenic transplant in some lymphomas. So they are additive treatments. They are not antagonistic at all.
Thank you, sir. Another question is from Dr. Hitha B. She has a primary mediastinal large B-cell lymphoma, stage 4, partial remission after DA epoch, dose adjusted R epoch, only 4 into 3 centimeter pericardiac mass, completely resected, IHC now shows few CD20 positive residual disease. If PET is positive at this point, which is better? Should we go for auto or should we go for CART? If PET is negative, we should observe or we should do anything else?
So observation is not an option at all. I believe this has been refractory, and for some reason it was surgically excised. When that's the little odd. Normally one doesn't do that; just does a biopsy, but it is excised. But even then, even if it is excised, one would definitely give further treatment. And in my opinion, the choice should be CAR-T.
Perfect. Another question is from Dr. Akansha Garg. Sir, any experience or any data of CAR-T or bispecific in mediastinal gray zone lymphoma?
I don't know, honestly. Not very clearly mentioned in in clinical trial data. Nobody talks about gray zone lymphoma, so I don't have the answer, to be honest with you.
Thank you, sir. Another question from Dr. Tejashwani Gudibande. Is there any role of molecular typing of DLBCL? Number one. And based on it, maintenance therapy of DLBCL?
No, so molecular classification of cytogenetic markers don't really decide whether you should go in for a CAR-T or a bispecific antibody. They work well in all types of molecular subtypes of DLBCL, so it won't matter so much. And there is currently no maintenance therapy for DLBCL.
And regarding any management difference based on the molecular typing?
I don't think so. In the context of the current immunotherapies that we're talking about, I don't think there's any difference in the management.
No, sir. Regarding the role of ecalbutinib or ibrutinib or addition of lenalidomide in DLBCL based on the molecular typing?
I honestly don't know the answer.
No issues.
If anybody else in the discussants knows the answer to that, you can chip in.
Because there was one talk last week only by Dr. Gaurav Prakash, and he was mentioning about the molecular typing in DLBCL as a precision medicine in India. Though the molecular typing has not come in back in India, but there are some molecular genetics which can help you to bring out that whether ibrutinib is helpful in young patients who are activated B cell type, DLBCL, and there are some molecular signatures. If those are positive, then ibrutinib works. Plus, if you add with R-CHOP, and there are some molecular signatures if you add len with R-CHOP. So that was he was talking about last week lecture. That's why somebody.
No, I have no knowledge of this, to be honest with you. I've never read about this.
No issue, sir. Yeah, so we have finished all the questions from the audience. Any discussion want to ask any other question? Okay, so let me just check 1 second. Yeah, perfect. Well, so sir, that brings to the end of the question answer session. Thank you so much for a wonderful lecture, very crystal clear lecture. And I think the knowledge of DLBCL has advanced like anything. And from tomorrow onwards, these challenging cases of DLBCL where we should go for CART, bispecific. It's very expensive, but should come streamlined in India also, sir. Thank you so much, sir. Fantastic lecture, lovely discussion. Thanks a lot.
Thank you. Thank you so much for inviting me, and thank you all the discussions for lovely questions.
Thank you, sir.
Thank you.